do. All right, everyone see it on the table.
Everybody see? You can put like a thumbs up in your reactions.
Looks great.
Awesome, awesome. Okay, hello everybody. Welcome to our Science and Health Policy Memo Writing Workshop. This is the first part in a two-part series. To give you a kind of introduction, I'm Jasmine George. I'm the president and founder of Morehouse School of Medicine, Health and Science Policy Group.
And I'm Raechel McKinley, and I'm the president of Howard University Science Policy Association.
Wonderful. So today we previously asked the students of Morehouse School of Medicine and Howard University to submit some topics that they would be interested in talking about and potentially writing a science policy review on. And here we have 6 topics that we're going to be talking about. How we kind of want to do this is the student who wrote the topic will have an opportunity to read what they have written. And for each topic, we can open the floor for discussion about what are some of the ways that you can improve this for a science policy memo. What are some things or extra comments or concerns regarding what they could do to address this public policy or social issue. And we will also hear a little bit from our reviewers as well on these topics and how to improve and go about improving this for a science policy memo. So next. So why are we here? A policy memo is a document that provides analysis or recommendations for a particular audience regarding a particular situation or problem. So typically the way that it goes is you describe the problem, you say who it affects, and what are some of the recommendations either at the federal or state level that you can do to improve it. So therefore, this seminar has 2 aims. 1, to give the students the opportunity to submit topics in social justice and science or health policy, and offer some kind of recommendation or even talk about what is being done at the federal or state level. And finally, 2, to learn about writing a policy memo and get feedback on the topics that we discussed, led by Dr. Bankston and her team.
So here I'm just going to introduce our reviewers. So we have Dr. Adriana Bankston, who is the Chief and Outreach Officer of the Journal of Science Policy and Governance, and she'll be a reviewer. We'll also have Dr. Stephanie Myers-Davis, who's the Program Coordinator of the National Heart, Lung, and Blood Institute. And lastly, we have Dr. Julian McCall, Co-Director of California Initiative to Advance Precision Medicine. So now let's jump into the topics. Jasmine, I'm going to hand it off.
Yeah. Okay. So the topic that I'm going to talk about is gentrification, eviction, and displacement, a public health issue. So gentrification is when the character of a poor urban area is changed by wealthier people moving in and changing the businesses, housing conditions, and subsequently displacing current inhabitants. Although the concept may seem like an overall improvement, racial injustices and inequity intertwine with gentrification. The gentrified area, typically associated with affluent or white individuals, often displace African American and Latinx communities and contribute to rampant systemic racism that is found in the United States government. In Atlanta, for instance, which is one of the fastest growing areas, is also ranked 5th in the most gentrified areas, where rent has increased 3 times every year since 2018. The current median in rent is around $1,474 a month in the Atlanta area. With these increases, Atlanta has also seen the highest eviction rates at 5.7% from 2015 to 2017. The increase in Atlanta's eviction rates is the highest among those with lower income at 8.3% and high income earners at 2.7%. Additionally, Data from the Atlanta Federal Reserve found that those at most risk for eviction are those from the African American and Latinx communities. So how is this a public health issue? So housing inequality from one of the many conditions, one of the many conditions that may negatively affect overall health outcomes. The World Health Organization described inadequate or insufficient housing as contributors to poor mental and cardiovascular health. Further, access to healthcare that would improve life quality could decline if the displaced move to neighborhoods with fewer healthcare resources. Many sources have supplied data that supports the notion that lower income earners are less likely to have a source of medical care. What can be done to fight housing inequality? Many proposals that fight housing inequality amid gentrification include expansion of public health care such as Medicaid to improve the health outcomes, preservation of affordable housing in high gentrification areas, encouragement of affordable housing development, and expanding the access to low-income housing and tax credits to incentivize the development of rent-controlled housing. In Atlanta, we're also looking to repeal the statewide ban on rent control, which allows landlords to increase the rent across the board. And also, so far, a ballot measure has passed in Georgia that exempts the property taxes on a public charity if the property is owned by a public charity. So this mostly targets places like Habitat for Humanity, which will allow people to purchase homes through them at an affordable rate and be ensured that their property taxes will not be charged to them. So that's kind of one step in the right direction as far as solving the gentrification, eviction, and displacement problem.
Thanks, Jasmine. That was really great in talking about gentrification and how this is a public health crisis. So is there any feedback for Jasmine as far as what we can add or any of your ideas and how we can kind of combat this problem that's occurring?
Yeah, any questions as well?
What do you consider a solution to?
Yeah, sure. The
gentrification.
Right. The easiest solution is to, as the city, because you don't want to necessarily tell the city of Atlanta to not grow. And that's not the resolution that any of the people who are advocating against gentrification and eviction and displacement are looking for. The easiest solution actually would be to reinstall the rent control. So that way there are more opportunities to open maybe several units that are rent control, or maybe certain houses or parts of neighborhoods that are rent controlled to maintain the integrity of these communities. That would be the first and foremost. I mean, of course, the ballot measure ensuring that there are no property taxes for lower income housing is good, but rent control would be optimal, especially in parts of places like Atlanta, where you're continuously seeing, the building of luxury apartments and things of that nature.
I have a question. Are there any model states that have, I guess, done well with gentrification?
That I'm unsure of, because a lot of states actually, I read some articles where majority, if not a lot of states in general banned rent control or have capped it at some way that kind of allows, a lot of landlords to increase their prices and as they see fit. So I can't really say that there's like a particular place. I guess you could say New York, because I did read that New York City had one of the highest amounts of neighborhoods that offered rent control, which allowed a lot of people to be able to live in the city and kind of go and use the city resources.
I had a question about the, I guess, I'm not sure if it's a law, but I remember you were talking about how the tax charities could get tax-free. The example you used was Habitat for Humanity. Is there a way, and I'm blanking on the decree or law, but is there any way to not make sure, but maybe like have a certain percentage or like houses specifically for like different areas for or have an increase in gentrification through Habitat Humanity, like have them just dedicate certain, like allocate certain houses or money for building houses, or I don't know.
Right. That would be an excellent addition to what's currently being done. As I said before, the removal of those property taxes that are pretty high in Georgia is a good step in allowing both Habitat for Humanity to give more properties to people at a more affordable rate. But there still needs to be, things put in place that can, give people the opportunity to get a house through there. I know access is a big problem, big issue. A lot of people who would benefit from something like this were displaced to like more rural areas, and the statistics for rural areas are even worse. So improving access is huge as well.
I had a comment. So I think wouldn't it be maybe a good idea maybe to try to implement something to kind of save certain small businesses that are already in the community. So maybe I don't know, maybe certain tax advantages for small businesses in the area, or maybe certain grants or something to help smaller businesses in the area, so that maybe they don't go out of business, or in terms of housing too, maybe helping with home ownership. So in terms of I think a lot of things also come down to lack of knowledge about certain things. So maybe educating people on certain like down payment assistance programs for home ownership, letting people know about affordable dwelling units that are in the city, policies that already exist. Because I think there's policies that are already implemented, but a lot of people don't necessarily know about them. Specifically, the people who are being displaced, they may not know about an affordable like dwelling unit that they qualify for. And so people who are less impacted, they may know about the affordable dwelling units or certain rent controlled apartments. However, the people who are being displaced, they don't necessarily know about those policies that are already in place. So maybe, trying to reach out to those communities, having like information sessions to let them know.
Yeah, I like that. I'm definitely gonna write that down.
Piggybacking off that, I feel like maybe banks would be like local banks maybe would be like a co-partnering, or they would have like information too and workshops to kind of do that as well. I know even in this area, there's like I think two Black banks over here too. I don't know.
Okay, I think I like that. I wrote that down. Any other questions, comments?
All right, well, let's move on to the next topic. Hold on, sorry. All right, up in smoke, the social justice issue of our time. Lawrence, you can take the floor.
Sure. I had a paragraph written out and I don't have access to it right now. So I'm just gonna go off my memory of when I looked into the topic for our discussion today. Cannabis is a Schedule 1 substance according to the FDA. So there's very limited research we can do on it, and it's highly regulated. So those in the scientific community, and of course it's illegal in many states, but as of last year, there's a growing number of states who are legalizing cannabis. I think there's up to 13 states right now. And as of last week, the MORE Act that was passed by the House of Representatives is now on to the Senate for approval. And if it does pass, it will federally legalize or decriminalize marijuana or cannabis, and it will lead to the pathway to where records can be expunged for use of the substance in the past, and also access to hospitals and other research enterprises to do studies on the substance. So criminalization of marijuana disproportionately affects communities of color and continues to do so, specifically the African American community, where there are more than 2 times incarcerated at the rate of their white counterparts. And so with the legalization of this substance in states that are predominantly Caucasian, the ones who are taking advantage of the legalization of the substance and making money off of the industry have disproportionately been white. So there is a social justice issue here where it's legal in some states and those of the people of color are being criminalized more, versus those who are in the industry or in states that are legal or actually benefit and profiting from this. So I think it will be an important important topic, health policy topic, where this not only affects public health, but it also affects the scientific community and its ability to study this and multiple sclerosis, the psychoactive effects of this, and cancer benefits as well, but also on the social justice aspect of it and the long-term cost that this can have in certain communities. In the past, we've seen what the impact of certain inequities and federal regulations, such as the GI Bill in 1946 or 47 that was passed, even though it was access to all veterans, not all veterans, particularly those of people of color, didn't have access to some of the loans for home ownership and also for access to colleges. They had to predominantly go to HBCUs. It was still under the Jim Crow laws. So, and that ripple effect has really impacted generations of individuals to this day. So I think that this particular time is really important because we have the opportunity to make sure that whatever laws do get passed by individual states, we can make sure that there's a health equity or social justice component in these laws, in these state laws going forward, to make sure that everyone has equal access and can benefit from the use and the profitability of cannabis.
I have a question.
Yes.
So is currently, are the only people who are doing research on marijuana like out of the academic realm, for instance, like private companies or companies in states? Okay.
Yeah, and other countries have different laws. So the research is advancing in like countries like Amsterdam or Sweden or things like, I think countries like that have more advanced research. But the medical benefits of cannabis are not that much at this current state, because we haven't really done a lot of research on it. So there's a lot more that can be done. And I think, kind of like how tobacco was the funding from lawsuits from the tobacco industry, they went into schools to educate and to foster research. So I think the same thing can be done with the cannabis legalization as a way of kind of righting a wrong. They can, whatever taxes that the state of Georgia makes, some of that money can go to Morehouse School of Medicine or Howard university for research as well.
I have a question also. Within the first couple of years that Colorado legalized marijuana, there's still like an age limit, I think 18 or over. And there was a thing where people noticed that they were still disproportionately arresting Black teens for possession of marijuana as opposed to white teens. Do you know of a way that probably could be mitigated in like other states that start legalizing it?
Yeah, that's a good question. I'm not sure. I think at the foundation of it is there's this disproportionate policing and poor and people of color, communities of color, just generally speaking. So even if it becomes legalized, there's all these stipulations where you can buy the product, you can't use it outside of your home, and from what I've read, a lot of these dispensaries, they're placed in lower economic neighborhoods, not like poor neighborhoods, but like they're not really in the suburbs, you know, and they're in the major cities. So they don't really want those dispensaries in their neighborhoods. So they have to go to other places to get it. And that's usually where, you know, people of color are. So I think really how we use a law, we got to really think about how this impacts the community. If this becomes legalized, you know, will teenagers and, you know, depending on where this is accessed, where these dispensaries are being built, you know, will teenagers have access to this and things like that? So I think a lot of thought and the public health, but also scientific community needs to, you know, come together and think this thing through before we just decriminalize it and have a free for all. I hope that answered the question. I'm not sure.
I have a comment. It says that I guess VP candidate now Kamala Harris sponsors a bill for the MORE Act. I didn't even know about the MORE Act until you just mentioned it just now, which I think is interesting. So maybe a portion of it could be definitely promotion, because it's not something that's like really in the forefront of public eye. And I'm curious to see what her explanation behind sponsoring this bill like. Because when was the bill proposed?
It's a good question. I'm not sure. I don't have that access to that information right now.
Okay.
But I can find out for you.
Oh, thanks.
Any more questions, Florence? If not, thank you for your topic, Lawrence. And then the next one is Disability Education and Research, Rasheera Dopson.
Hello. So I'm just going to give a brief overview. I didn't throw this together, but just my first time doing this. So I hope it makes sense to you like it does to me. And I'm going to read off my paper. Just give a general overview. So the Americans with Disability Act, also known as the ADA, was signed into law on July 26, 1990 by President George H.W. Bush. And it stands for Information Technical Assistance for Americans with Disability Act. That's where I got my reference from. And basically, the ADA defines disability as a physical or mental impairment that substantially limits one or more major life activities, a person who has a history or record of such impairment, or a person who is perceived by others as having such an impairment. And so when we look at the scope of disability, it can be seen in two different frameworks, the social model and the medical model. And currently our healthcare field looks at disability through the lens of the medical model, which approaches disability as a physical condition affecting an individual, which can hinder the quality of life. As compared to the social model that looks at society as a whole and how we adapt to people with disability and creating concepts such as universal design. And so when we're looking at disability, health, education, and research, the proposal I kind of came up with is to think about how we construct future health policies that affect specifically for people with disabilities. And I think a good example of looking at that is COVID-19 and their crisis. A lot of underserved populations, which also include people with disabilities, they were kind of left out of the emergency response readiness. And so when we look into the future and creating further health policies, even we can say marijuana or things such as gentrification, all of these that affect our population as a whole, when we break it down to more smaller demographics, such as people with disabilities, how are those people thought about when these laws are being created? And so I don't know if this would be like more of a call to action along with education and creating a policy, where we can put in the forefront of people's minds that when we're making health policy, to make sure that we're looking at all demographics of people and underserved populations. I think we've done a pretty good job of making sure that minority populations such as African American, Latinx communities, Native American demographics are included in those studies. But when we look at NIH, other government websites, when they're listing subpopulations or underserved populations, people with disabilities are not on that list, and they make up the biggest minority. 54 million people in America identify as having disabilities, so they're the biggest minority and the largest demographic. And so just keeping, I don't know how that would look, in framing a policy that can make sure that that language is included in all health policy moving forward, especially after COVID-19. They had to do a lot of restructuring, like, okay, we're getting the vaccine to people, but what about people with pre-existing conditions, people with disabilities and their access to healthcare and different things like that. So being more intentional about including the language of the disability community in all health policy. So that's my spiel. Any questions?
Yeah, I have a question / comment. This is a very interesting thing that even as an able-bodied person has not thought about. And so I'm wondering if there needs to be more disability education in elementary schools or at the school level as well. And what would be what would that kind of look like, and what would be some recommendations there?
That's a good idea. Thank you.
I got a comment or maybe a question. I know that the Disabilities Act that was passed, from my understanding of it, it was supposed to be that whatever policies created, whether it be around employment, housing, etc., has to address disability rights. Mm-hmm. So I think that it extends to health as well, but maybe we can maybe propose a policy recommendation to kind of revamp it for the 21st century, maybe to see what kind of holes are there, and see if we can kind of fill in those gaps and make it better.
And you're right. I think that's where the research part comes in, because the ADA really, it's kind of a law for compliance, making sure buildings are accessible, that schools are making sure that they're educating their special needs students. So more so on the lines of accommodation in the healthcare field, making sure that, all of your services are accessible. But I don't, like I said, that was made, like you said, that was created in 1994. I think a possible revamping of the language of the ADA to be more specific, because a lot of those laws, they were implemented in the early 90s and a lot hasn't changed since then. So I definitely think going back to education and maybe expanding the scope of what does that look like in 21st century modern day society, as to making sure that people have equal access across all boards. So thank you.
Any more questions for Rasheera? All right, well, thank you so much for your input and ideas on this important topic, Rasheera. The next slide is addressing recruitment and retention challenges of minority ethnic populations in biomedical research. Karyn, I hope I'm pronouncing your name right, Karyn Onyeneho.
You're correct. Hi, can you hear me?
Yes.
Yes, thank you so much. Greetings, everyone. My name is Karyn Onyeneho, and I'm currently a PhD student at Howard University. I'm also affiliated with the newly founded Howard University Science Policy Association, as you may know, through Raechel McKinley, our president. And I'm really happy to be a part of this discussion. I think all the topics have been really instrumental. And the last topic is really important to me, and it ties in with what my topic is, with addressing recruitment and retention challenges of minority and ethnic populations in biomedical research. So I'm just going to go through my points and sub-bullets and then open up the floor for questions or comments. We know, just based on the last presenter, that there are disadvantaged populations in the United States that are understudied in research, i.e. persons with disability, i.e. minority ethnic populations. With regard to African Americans, there is a paucity of African Americans participating in health-related research. And this has often been attributed to difficulty in recruiting and retaining African Americans and other minority ethnic populations. The reasons for such unwillingness to participate in research has been unclear in certain respects, but we know could account for health disparities that have been driving a lot of what we've seen, not only in the COVID-19 related deaths, but other chronic illnesses and morbidity in the United States. There have been studies across the board that have demonstrated that African Americans may be more difficult to recruit and retain in health-related studies due to various pervasive factors. That could include psychosocial impacts, cultural beliefs, and other issues. We know that historically, recruitment and retention challenges have impacted African American communities in particular, disproportionate to white populations or persons of European ancestry. We know that these factors have been known to both affect participation and influence health disparities involving research, all of which may lead to premature death, reduced quality of life, missed economic opportunities, inequalities, and inequities. Most recently, I conducted a systematic literature review that was published last year with the American Society of Nutrition that actually looked at a number of articles between 10 years, identifying what are those barriers that are impacting African Americans and other minority populations from participating in health-related research, particularly research that involves DNA sampling. And I found that a total of 37 articles met my inclusion criteria to understand what are those barriers. Results were based on feedback that was conducted from trained research assistants and phlebotomists, whether it was in group, face-to-face, or telephonic interviews. The results revealed that African Americans and other minority populations, but in this case, African Americans in particular, have been apprehensive when it comes to participating or remaining in these types of studies for various factors. And some of the examples are in the sub-bullet under 3 and include perceived and or actual experiences of mistrust and deceptiveness with investigators, including the research community and personnel, misuse of health information or genomic data that involves DNA, unethical research practices, which we all know too well about when we think about the syphilis study, healthcare system distrust, and we're seeing that now with COVID-related cases, privacy concerns, socioeconomic influences, cultural beliefs, and other influences. We know that it is vital that we build connections with these communities in the science community so that we can bridge health disparity and other types of, I would say, adverse impacts that are impacting these communities. And I think that science policy involving how do we address recruitment and retention challenges affecting minority populations. And I point to African Americans in particular because we have history of knowing that this is a marginalized group, both underrepresented and underserved in biomedical research. I believe that it is important to address these factors among various diverse populations, and African Americans in particular, who we know have not been largely represented in these types of studies, in order to promote better health outcomes and to understand how to prevent and treat disease. And I think that once we do devise an incentive, I think an incentive to inform science policy that would help us address these issues, we may be able to, I hope, see more African Americans and other ethnic populations of color, not only participating and staying in research studies involving DNA, but also benefiting from these studies. Now, I did do a little bit of research and I found that there was an article, and we might all already know this all too well, that was published this year, indicating from the census that by the year 2045, the United States will become a majority minority, where whites or persons of European ancestry will be considered a minority. Again, kind of just alluding to the importance of ensuring that African Americans and other minority ethnic populations of color are not only recruited, but retained in biomedical research studies, including those that are clinical trials. I also wanted to point out that recently the FDA, and this was a study that was published in 2020, revealed that cancer drug approved trials, there were 31 cancer drug approved trials by the FDA in 2015, where fewer than 5% of African Americans were represented in 24 out of the 31 trials, even though we know that African Americans make up nearly 13.5% of the US population. These cancer drug approved clinical trials were actually targeting cancers that are known to be disproportionately affecting African American communities when we compare it to persons of European ancestry. In 2011, a woman by the name of Donna Ginther indicated that in large portion, recruitment and retention challenges not only have to do with subjects that are being recruited, but also the scientists who are also in charge of developing recruitment strategies. We know that when scientists don't resemble the communities in which they are seeking to bridge the disparity gap in, that is permeates health disparities. And so I thought that this would be one of many important science policy topics that we might want to address, given what we've not only seen historically over the last several decades when it comes to health disparities impacting communities of color, but also considering the changes going to happen in the next several decades, at least in 2045, where the United States demography will become a majority minority representing communities of color. Happy to take any questions. Thank you.
I have a comment. I think this is a really big topic, especially, and we're in COVID and pandemic. And I happened to see an article today come up on my phone about the first batch of vaccines going out. And I thought it was funny how the person who was taking the vaccine shot was a Black woman. So I knew that wasn't by accident, that was very purposeful. In that conversation, I don't know if you guys follow a lot of conversation on Black Twitter and a lot of the Black social circles about people not wanting to take the vaccine. So I thought that was an interesting narrative, trying to portray that the Black demographic is open to taking the vaccine. So I think this is very necessary. And probably within the next year, we need to kind of get more on this.
No, thank you so much, Rasheera, for saying that. And I completely agree. We know most recently, at least with the news coming out of the NIH, Dr. And I apologize, Dr. Corbett, I believe her first name is Kamika Corbett. She's leading one of the vaccine trials at the NIH. She's an African-American fellow, and she's been really instrumental in not only sharing information about what are viral infections, what is COVID, and how can vaccines actually address this pandemic. She has also been involved a great deal with really just demonstrating effectiveness. And I agree, I think that with a face that resembles someone that looks like myself, I probably would be more keen or less reluctant to want to be involved. I think that what you just brought up as one of the biggest drivers is health literacy, health education. I think that once we incorporate health literacy and health education into therapies, into interventions, into preventive health services, and we can probably, and just probably, narrow the gap when we think about recruitment and retention, primarily those impacting communities of color. So I agree wholeheartedly. And I don't think that this is going anywhere, and nor should it, right? And we see that now with COVID cases. So I really appreciate your feedback.
Yeah, oh, I'm sorry. Was someone else about to speak?
Yeah.
Oh, no, you can go.
Okay. I had kind of like a question about reframing maybe. Because I know a lot of like the time that we try and figure out why African Americans don't trust like clinical trials and medical care and all that. But like, why don't we like try and flip it and be like, why isn't medical research and medicine in general more trustworthy? Because people don't have this distrust for no reason. And if we try like work on what it is about healthcare providers and researchers that they don't trust, they might get further than like trying to figure out why they don't trust.
You know, I agree with you, because human experimentation, as we know, stems far before the syphilis study. We know that a lot of other ethnic minority populations have not largely benefited, but also have been used as subjects in an abusive manner. And I think it's okay to talk about the truth. I think that that's probably another driver that keeps folks apprehensive and wanting to be involved, because they don't know, right? We think about the syphilis study, but what happened after that, right? How do we actually create transparency so that there is, in my opinion, we invite subjects to research as partners, right? So that we're not just using research subjects just to sort of check off a list that we've met our threshold of African-American human subjects. I think it's vitally important that we start talking about some of these cases so that we can just enhance and increase health literacy. And I think that that's important, because the syphilis study is really just one of many, right? And I think that once we educate and we increase literacy, we can start, I think, inviting more and more questions to come, so that individuals, families, and communities, they feel like they're a part of it. They're a part of actually contributing to increasing our efforts in recruitment. Because I completely agree. Those psychosocial factors, I think, is what's continuing to drive a lot of what we see in the data. And I only pulled articles from the last 10 years, beginning in 2018 to 2018, demonstrating, some of what individuals who were interviewed are saying about why they don't want to participate. Some of them really don't even know, what are you going to do with my DNA once you do have it? How can I benefit? How exactly am I going to learn what occurs after my DNA is used? And I will bring up that the National Institutes of Health, apart from other studies in the United Kingdom, is leading a longitudinal study to recruit 1 million or more Americans so that we can understand what's happening, not just from the perspective of chronic illnesses affecting all, but particularly what we call underrepresented populations in biomedical research, i.e. African Americans, women, individuals who are titled as persons with disability, which is what Rasheera had also mentioned previously. And I think it's a really important health literacy and health education, to me, are one of the key drivers, I think, to address this very, very important issue. Thank you so much for your comment. Raechel, I think you had a question.
Oh, well, yeah, no, I had a comment. So like, I was going to say, I think something also that needs to be addressed is, transparency. I feel like there's a lack of transparency, and people want, especially people in these different minority ethnic populations, want to see transparency, right? And they want it in, language that they can understand. So I think there needs to be more transparency. So kind of like what you're saying in terms of education, but making sure that, it's transparent enough. I think that's kind of what's lacking as well.
I completely agree with you. And that's something else that I've seen, like using jargon and terms that are unfamiliar with individuals, I think is also another driver. And relative to the US population, I think that researchers are responsible to make sure that literature and information is being shared is at an appropriate reading level. And I think right now the threshold is at the 5th grade reading level when you talk about information that's promulgated publicly. And I couldn't agree with you more. And for example, genomic research, people don't understand what is that, right? We can use certain terms as DNA. I think most of us recognize what DNA means. And I think it is important. I think we need to create sort of this repository or a standardized approach as researchers and how we convey information in layman's terms, it's vitally important. In fact, I think I came across an article recently where individuals weren't even sure what DNA meant exactly, you know, because they haven't heard of it in the sense of, you're using my DNA to benefit me how, or for altruistic purposes how. So I couldn't agree with you more. Transparency, health education, health literacy, and really understanding what are the drivers from both the past, present, and even perhaps the future when we think about what the census has reported that's impacting ethnic communities, especially African Americans, from participating in research. And yeah, I think that this is something that we're not going to stop talking about, especially now that we have our first vice president who is a member of some of these groups that we know are underrepresented and underserved.
Awesome. We actually have a couple of more comments or questions. One is from Zakia Ali. She says, if general healthcare practices treated African Americans with more care, we wouldn't be so skeptical during times of crisis. And additionally, we have Tiara Griffin here with another barrier to participation is the ability of African Americans to take off work to participate in clinical trials.
Yeah, I really agree with those 2 points. The first one I will address. I agree. It's sort of a double-edged sword, right? Because if we have issues recruiting and retaining human subjects in clinical trials based on the fact that they don't trust the healthcare system or they don't trust researchers, I think that it's important that we ensure that the communities that are being recruited are resembled in the researcher workforce. For example, I'm a researcher and I'm interested in conducting research in African American communities. But if there are not a lot of researchers who are African American or who are African American female, then I can't expect the future to resemble the kinds of research that I'm interested in, because I think there's another systemic barrier there preventing people of color from entering PhD programs, for example, or entering fellowships, for example, or postdoctoral opportunities that would otherwise allow individuals to conduct their research. That's another issue. And if you think about it, it's almost, in my opinion, creating the systemic issue that we're talking about, right? Because you don't have researchers that look like the communities that are being marginalized. The communities that are being marginalized don't trust the research community because they don't look like them. Then it creates sort of this tunnel of, you know what, I don't want to be involved. I'm scared, I'm apprehensive. And we really are driving what we've already seen historically happening. So I couldn't agree with you more. As far as individuals, for example, African Americans not being able to take off work, I did come across that as a confounding factor when we talk about recruitment and retention challenges, because a lot of the protocols or research protocols are not providing incentives in order to actually help subjects, or I wouldn't say help them, but incentivize subjects in wanting to be a part of research. Some of them did, for example, offering rides or Uber or taxi or child subsidy. But a lot of the individuals who you mentioned, for example, aren't able to participate in research because they have jobs. That's another issue. That's right, a socioeconomic issue, right? These are the same individuals that we want in research, not being able to afford time from work because they have other, issues that are impacting them. So I think there are a myriad of issues that we could sort of, address when we talk about disparities in recruitment and retention. I couldn't agree more. I think that these are all pervasive factors, and if not addressed, we're going to continue to see less representation of African American and other ethnic minority populations in research, and thus we're not going to be largely represented, and that's going to drive the fact that we're not going to benefit largely as we probably could otherwise.
So I have two things I wanted to mention. Like one, one is I'm wondering, with there being, so there's the distrust from the public, but then is there also an issue with the amount of effort that there's being put into recruitment of African Americans and other ethnic minorities?
That's a really good point. I know that, and well, I'm not going to say I know, but for example, I'll take the NIH, which is the world's largest biomedical research agency. We know that the National Institutes of Health has several institutes, and their primary job is to provide funding, whether it's to institutions or to independent researchers, to allow them to carry out their research. NIH, as one of the largest funders of biomedical research, has an incentive in their application. I'm going to call it an incentive, has a method to incentivize researchers with a diversity statement. And this was actually revised in 2019 to address underrepresented communities, not just on the basis of ethnicity, but also gender. And also, as Rasheera pointed out, individuals who are from disabled populations. NIH does have a policy statement to address diversity in underrepresented communities, to sort of advise researchers or institutions that are seeking government funding that this has to be a component of your research protocol. And so I think that that is really important. I think that we have to have more representation, not just at the federal level, but also at the state and local level, to make sure that we're providing opportunities, not just to understand that, hey, these disparities are very real, but hey, here's what we can do in order to actually address these disparities, at least if you want funding from state, local, or federal government.
And the other thing I was thinking is that aside from, the racist history that we have, when it comes to medical experimentation, I feel like the healthcare system in general for the whole public has lost a lot of trust, and I think there's a lot of reasons for that. But I'm wondering, what different ways there are to combat that. I mean, I think part of it is that people get frustrated with the lack of holistic care, meaning, there's a lot of medications pushed towards, different health ailments, rather, we're not talking about nutrition as much. We're not talking about, physical activity as much. We're not talking about physical therapy as much. We're talking more about surgery. We're talking more about medications. And that goes across the board for, all different areas of health. And I think there's a large distrust. I work in fitness, for example, and, I have a lot of people who are like, oh, what's my doctor going to tell me? Like, there's a lot of that attitude from people across the board. And, and I think it's a big issue, because I think it's going to take a long time and a lot of effort to be able to overhaul that, because it's an issue with the healthcare system across the board.
Yeah, no, I couldn't agree with you more. In fact, I was actually just looking at the Patient Protection and Affordability Care Act, which is now known as Obamacare. And one of the greatest, I think, one of the greatest things that came out of that was making sure that insurance companies cannot deny an individual from receiving health benefits, whether it's through a health care facility or some other health service, can't be denied based on a pre-existing health condition. I think that the more and more that we have advocacy efforts being advocated for across the board, whether it's at the medical center level or at the institutional level or at the independent researcher level, to actually address this, the more we'll probably see changes. I also know that I agree with you. A lot of the issues that we see are across the board, with, at least in regards to this topic, with addressing recruitment and retention challenges. There are so many different pockets of this, but I really think that we have an opportunity to really investigate how do we actually look at this at a macro level view. One thing that I would recommend, from the perspective of addressing this as a national issue, is to diversify the student faculty population at institutions, especially those who aren't receiving funding from whether it's federal, state, or local, so that we begin to reflect the demography of the United States. I mean, we're seeing that now, but it's going to be a lot more pronounced between now and I would say the 30s and 40s. And I think that if we don't address that, if we're not resembling the same nation that we know has represents a large portion, at least in the example that I gave, African Americans make up nearly 13.5% of the US population. If we don't address these issues, that number is going to drive itself up, I think, double that amount, even before we get to 2045. And so I couldn't agree with you more. I think that this is a topic that we're going to continue to talk about until we see change. And it's going to be incremental change. As long as it took us to get here, I think it's as long as it's going to take us to actually not get out, but at least narrow the gap.
Awesome. Thank you so much. And I will bring everybody to the attention of Dr. Bankston's comment. Kenny Gibbs has written a little bit about this. So if you're looking to see some other perspectives, I would encourage you to follow the link. And we're also going to move on to our next topic, which is diversity and COVID-19 clinical studies by Raechel McKinley.
Hi, everyone. So my topic is kind of similar to Karyn's topic, but it's more targeted towards the COVID-19 vaccination clinical study. So I decided to come up with this topic based off of some of the articles that I've been reading about the clinical trials that have currently been going on. And I've noticed that some of these studies are actually kind of being praised for being more diverse, and I actually am finding that they're not necessarily as diverse, or actually they're not actually representing the diversity that we have in this country. For instance, I was reading an article by the New England Journal of Medicine, and I saw that the percent for African Americans was only 9%. And I feel like maybe in terms of most clinical trials, maybe it was more than normal. However, I don't think that it is indicative of the population that we have in America of African Americans. And I feel like that's a problem, especially because when it comes to the COVID-19 virus, that African Americans and Latino and Indigenous populations are more disproportionately affected when it comes to COVID-19. However, when I was looking at the numbers, I think it was like 86% of the population for the study was Caucasian. Is that really indicative of the population that you actually want to target for the vaccine? It's more indicative of the population of the US, which is important, yes. However, if the virus is affecting these populations more, then there needs to be more policies that actually recruit and retain more African Americans and Latinos for the clinical studies for COVID-19. And so for my topic is mostly, I believe that if we were to write more, to induce more policies in terms of getting more, and I think also that it, in terms of getting, because there's a lot of apprehension in these communities to actually take part in these studies on the other side. But kind of how I think someone earlier said that the first person that they showed that took the vaccine was an African American woman. And I think that was because of that apprehension that is taking place. And so I'm actually not mad at that, but I think that there needs to be more than just, oh, look, that we have an African American woman who has taken a vaccine, you should too. It's a lot more than that. And kind of how I was saying, transparency, I think, because there are a lot of articles that are coming out, and yes, those articles are public. However, there needs to be more articles that are written in layman terms for everyday people to understand what these clinical studies mean. And maybe if people can understand more about the vaccines, that they will take part in these clinical studies. So for my topic, most of what I want to write about is actually, including like more transparency and articles for people having more research teams that reflect the population. So more African American, Latino researchers and doctors and other healthcare professionals to push for that to go into the community and to kind of build more of a trust between the scientific and research community and these underrepresented and underserved populations. So are there any questions or comments?
I just wanted to comment, I really love this, and I think it ties into what Rasheera, myself, and you were talking about, that representation is key. And when we think about these underserved and underrepresented communities, because those are two things, underrepresentation and being underserved, we know that this is what's driving health disparities. This is what's driving health outcomes. And I think with COVID, we're seeing that now. And I think that this is really an incredibly important topic to address.
Absolutely. I have a question, actually. Do you think that these interventions about COVID-19 should best be served on the state or federal level?
I think that's a great question. Actually, I'll say both. I think that there does need to be something done at at both levels. I think in terms of the state, mostly because I'm sorry, I'm trying to get my thoughts together. You know, for especially because for certain areas specifically in certain states where you have more populations of different groups, I think that is important to specifically have policies for those states who may have more underserved and underrepresented populations, right? And then I think on the federal level, and I also think that things will possibly, it may have more impact at the state level versus the federal level, or maybe easier to be implemented at the state level versus trying to make it a federal um, um, making it a federal policy. But I think trying to implement it at both the state and federal level would probably be good. I would probably try and tackle at the state level first, though.
I have a comment on that.
Yeah.
Maybe if there were like a federal incentive for states to reduce their health disparities, that could be how they could like tie together.
Oh, I like that.
There'd be more effort by the states to decrease it.
Yeah. No, I like that. I like that. I like that.
But I also have a comment that's or a question that can go either to this slide or the one before this.
Mm-hmm.
Like, I like the idea of like there being like initiatives to like inform communities about what studies are going on and like what they're about and how they can be improved by that, and like in an effort to reduce health disparities and stuff. But how do you guys think about there also being the other side of that, of there being also like learning initiatives and things of that nature for people in the medical community to be better at that? Because a lot of the health disparities we see are because of like racism by healthcare providers. And no matter how much African Americans know about what's going on, it's not going to stop the healthcare providers from being the way they are. Yeah. So maybe there should be some kind of initiatives for that. No. Like, included in these types of plans.
No, I agree. I feel like maybe there needs to be more training, like continuing medical education, CME, workshops on like implicit bias, microaggressions for everyone, because I think that
is there like somebody you can like report your doctor to if you feel like they're being like unfair to you in some way? Is there somebody you can go to? Is that publicized?
Yeah,
like a reporting agency.
Yeah, I mean, I'm actually not sure. There may be, but I think, yeah, making that information public, you know, because I think that there are a lot of healthcare workers who probably aren't in the right field and they miss gosh, I can't find the word.
I remember like I don't know, I feel like it's been like put out there that a large percentage of the health disparities we see are because of racism rather than like there being literal like differences in bodies, you know?
Mm-hmm.
I'd like to comment on that. I think Raechel made a good point. And your question and comment is well received, Ariel. I can say that there is a website that I highly recommend called healthgrades.com. I've been using it for years. And I don't think a lot of people know that it exists, where you can actually rate your healthcare provider, no matter what practice discipline that they're in, on the basis of service. And in this case, any perceived or actual experiences of discrimination, bigotry, racism, or anything that is an individual perceives as they're being marginalized. I will also comment, at least on the federal level, I'm currently with the National Institutes of Health. And recently, as of this year, some of the African-American biomedical researchers formed what's called ACRE. It's an acronym starting with the number 8, followed by CRE, pronounced ACRE. And it represents 8 changes for racial equity within the National Institutes of Health, which again is the largest biomedical research facility, we know that there are percentages upon percentages within the NIH that make up, I would say, a population on the basis of ethnicity more from persons of European ancestry. At least in this regard, ACRE was developed. I'm actually looking at their website. They were created based on being motivated to ensure that the NIH workplace culture is free from racism, discrimination, and harassment. And this is a public, this information is publicly available. If any one of us wants to be involved, they do have conference calls that happen routinely. In fact, there was one that just happened on Friday to actually encourage more of us to be involved in how do we actually address, identify, eradicate diversity, inclusion, or issues surrounding anti-racism as a national priority when we think about the workforce. Because I definitely agree, the workforce is what we often can attribute, whether it's the medical workforce or healthcare personnel. Folks have indicated over decades that is a driver of mistrust and distrust. And until that's addressed, I'm not really sure if any of the other issues are really going to get or have a large impact. But I agree with you 100%, Ariel. And thank you, Raechel, for this very, very important topic.
Thank you.
I want to make a brief comment. I think, Raechel, your topic is very timely and kind of adding on to what Ariel was saying. I think we're in a very prime time. I even think with this new administration, we are starting to see a lot of models popping up that are starting to address racism and systemic oppression in the different fields. I know I've seen in the news a couple of times, Google has come under fire for their workplace hostility towards people of color. And so I believe now is the time for the healthcare field that limelight is being shone on about, like you were saying, Karyn, eradicating systemic oppression and racism in the fields of biomedical research. So I think this is it's very timely, and us as future researchers and policymakers, I think I just want to put out there that as we're talking, discussing these different things, like really thinking about actionable items that we can take and actually start implementing, really capitalizing on this new set of 4 years and making sure we don't lose that momentum. So I just kind of want to say that.
Kind of piggybacking on, I think it was Ariel's comment about, where to go if you feel like you've been discriminated against. Because, there are divisions, like, we're all familiar with like the EEO. And then there's like things like the Real Estate Commission, if you have any issues with, your home buying process. Like divisions like that are on the either the federal or local level. It'd be interesting because I'm definitely not aware myself. So it'd be definitely interesting to research if there's entities that exist for discrimination that specifically addresses discrimination in healthcare.
Like, how do you call the manager on your doctor? That type of thing. Like,
and outside of the hospital, going above, beyond the hospital. Yeah, you can go to right, because you could go to the hospital, whoever the supervisor, whoever, at the hospital, but what happens when that's not enough? Like,
like, can the doctor have like some kind of record where like maybe 15 people have commented having the same issue with him, like there being like a federal record of him being discriminatory, that kind of thing. Like,
the thing is that what that makes me think of too is that I know you can look up different doctors and like if they've had their license suspended at any point, if their license, but that's like all on record and you can read what happened, they were caught with drugs or whatever the case was. So there has to be something, and it's not, obviously it's
that's
not
usually like crimes and stuff though, right? It's not necessarily like a,
I don't know. I honestly don't know. So that's possible. Is it, if it's not considered criminal, will it, if it's, they're not supposed to discriminate. Like that's, they're not supposed to do that. So I don't know. That's a good question, but I think it'd definitely be worth looking into to see if those entities exist and creating some kind of database, because it's obviously something that people aren't aware of. Don't have access to. So,
and one thing I'd like to comment on both Marita and Ariel's comment. One thing that I have seen and I would encourage or advocate for is the institution implementation of offices, whether it's at a healthcare facility or at an organization like the NIH, that are designed, developed to address these types of systemic issues of racism. For example, an equity, diversity, and inclusion office. I think that if we advocated for more of that being instituted across the board, and we had sort of an officer, like a chief diversity officer and a team of subject matter experts who are constantly sort of surveying any acts of discrimination, whether reported or perceived, that we could probably, bring this or amplify this issue a lot more. Because I would love to know perhaps how many organizations involving healthcare, medical care, or otherwise actually have these types of offices that exist. And if they don't exist, why? And if they can't exist, how can we change that narrative?
And is there like a board? I have no idea, but like, is there like a board or something that what umbrella like kind of oversees like all hospitals and clinics and any kind of medical care facilities? I would guess there's some kind of entity that oversees all of that, and that like the type of office that you're talking about, diversity and inclusion office, like that should be included within that office, I would think. But yeah, I know there has to be, but I have no idea.
So there's what's called under the U.S. Equal Employment Opportunity Commission, or otherwise known as the EEOC. They have what's called the Healthcare Workers and Americans with Disabilities Act, provisions that actually go against or prohibit any acts of discrimination, whether it's on persons based on their disability, ethnicity, or otherwise. And I agree. And this is another part of education that I think is important, because a lot of us don't know that these things exist. And I think that the more that we share information at a macro level view, then maybe this can start becoming an issue that a lot of us can understand, not just because we're researchers or biomedical professionals. So I agree with you 100%.
Wonderful. Thank you so much, everybody. This is great. Just wanted to move on to the next thing to get the last but not least presentation out of the way. Alrighty, and we can start. There you go.
Hi, good evening, everyone. Yes, I'm the last but not the least. I would like to thank Raechel and Karyn for their wonderful presentation. And I feel like as a collective for the Howard group, we had quite the discussion about our topics that was very intense about how we were feeling. We felt some type of way. So yes, my topic is developing policy guidelines on terminology regarding underserved and underrepresented populations. So as we know, the current terminology for addressing underserved and underrepresented populations is referring to those populations as minorities or diverse populations. However, does this terminology actually help to develop policies for those populations? And that's where I kind of developed the question. And the examples that we used were when using the term minority populations in training programs geared towards underrepresented populations in STEM, but using language that includes populations that are not underrepresented in STEM, it's kind of counterproductive and leads the target population to not being served. So I need more feedback and help. So I'm ready for everybody's suggestions and questions.
Yeah, absolutely. I do have a question. So what are some of the terminologies that could be used in place of the current ones?
Well, so my thing was just making it as specific as possible, because sometimes in a lot of research papers that we use that are used, it just states that it's underrepresented and it can be bunched together. So it looks like we've met the quota, but we haven't really addressed where the deficiency or the marginalization is, and making it a priority of, okay, Black Americans and diabetes. This is what we need to focus on. But it just talks about or groups us together with Native Americans, Southeast Asians, Hispanics. So there's no way to actually focus and identify the problem at hand.
Yeah, I agree. I'm all for being specific. One term that I find, I understand why it's used, but I find it really annoying in many ways, is people of color. I'm like, good God. Like, you know what I mean? It's just so, and sometimes I've found people using people of color when they're really talking about African Americans. I was like, we're talking about Black folks, let's just talk about Black folks. People of color. I'm just like, some things are about everybody and some things aren't, I also, I have issue with the way that Latino was used in research, because I'm like, Latino, I'm like, you might as well say American. I'm like, because I'm like, and the thing is like what it seems like is when they're using Latino, is it's like, okay, Latino, but not Black Latinos and not white Latinos.
Exactly. What do you mean?
In the middle where which I think is interesting too, because I'm like, good gosh, this is like another issue too, because I'm like, Latino is so it's just as diverse as saying you're American, and it literally means the same thing, but it's been used in different ways. So I think there's a lot of room to like, yeah, let's get specific, because there's different issues that affect different groups of people. And when we, just use these umbrella terms, a lot of that is lost. And yeah, when it, like you said, it looks like we're meeting the quota when we're really not.
Yes, I definitely think having specificity in research actually addresses a lot of the issues that we were having beforehand for a lot of the topics that we talked about, because the impact of that is actually increasing for other like-minded individuals or same race individuals to see, okay, so they're focused on us. This is how we can show our background. Hey, we have information about you. We have information on genetics. We have information on cholesterol. Because a lot of the times, us as researchers, when we go look for a lot of, for instance, my background right now is in a lot of neurodegenerative disease disorders. So I'm unable to find certain rates or disorder prevalencies in African Americans specifically, but they'll tell me everything else that I don't need to know. So it's very important information, but not to what I need to focus on specifically.
I have a comment for you, Collis. I think that this is another important topic. And to Marita's point, we know that historically there have been various terms, at least in the diaspora, in the sphere of Blacks or African Americans, that have been used, from Negro all the way now to BIPOC. I think that I'll say two things. We probably should, and I say we as a nation, probably should align any science policy that we develop to address this topic of Collis's, which is developing guidelines on standardized terminology to use to describe each population, should align with the census. We know that the census is what has been used sort of as a mechanism in this country to collect data on certain groups. And right now, the census has various categories, but when it comes to ethnicity, they're actually using Black or African American to describe this group, which I don't necessarily think represents us that well. And I agree that this is a topic that we should delve into. The other thing I wanted to point out is a point that Collis made. Race is really a social construct at the end of the day. So are we really actually even using Black and African American appropriately when we think about genealogy? If I were to describe myself, I would want to be described on the basis of my ethnicity or my place of origin in certain contexts, especially if we're talking about health outcomes or healthcare services, things of that nature, versus, or benefits of healthcare research, versus me being sort of bucketed under this umbrella as Black. Because I don't think that is an accurate description when I think about, I don't know, genetic testing. If I'm a candidate for a BRCA1 gene that we know predisposes you to breast cancer, I would want to know how is that data derived? Is it actually based on genetics, or is it based on self-reporting from individuals who just by mere physical attributes believe that they fall into a certain racial category? And yeah, I think that, like you pointed out, Collis, it is very vague to just use certain terms as diverse or minority, when that's not really an accurate description, at least when we're talking about medicine, health, and even nutrition to address health disparities. I think it should be based on our genes and our genetics.
I mean, I think you and I actually have had a little more conversation on this that we started to touch on, but like, yeah, I think one thing too, you know, when we talk about Africans and then we talk about African Americans, you know, like that, I think a lot could be accomplished from studying those two groups separately, you know, because I mean, just the historic background right away is incredibly different from the diversity of African Americans, the racial diversity of African Americans, right? And then also, what comes with being, you know, of African American descent within the US, you know, the history of that, you know, and then versus, you know, Africans coming who are only first generation, second generation Africans in the US, and what that comes with, and the ethnic diversity that's with that. You know, we're talking about two different groups of people that do look different in many different ways. And how is that reflected in research? How is that reflected in medicine? So I mean, I think that would be amazing to see. And I think, you know, it would look I think there's a lot that we could see from that. And, you know, even using studies together, you know, as far as like, okay, well, is this a genetic issue or is this more of an environmental issue? You know, by doing, you know, so I don't know. Yeah, I think that's worthwhile looking at, and it'd be nice to see that at some point.
Like maybe policy to make sure that when people have like these large groups, let's say I have a subject group in my clinical trial that says just Black. Maybe I should be more specific within that group and say Black with XYZ heritage or Black from XYZ area in the United States or outside the United States. So just so when people come by and want to use my study for their research, they know exactly what people I'm talking about and what their culture is and how it's affected by their study and all that.
Yes, definitely.
And I also want to add is also making sure that, again, back to what I propose with disabilities, people with disabilities, because oftentimes that demographic is left out. And so when you get more to the granular levels of people within that demographic, Black people with disabilities, that is often missed a lot. And there's little to no research on the different minority groups that have populations with people with disabilities. And a lot of research, they focus more on condition specific and more generalized term. And so we are really missing it, especially when you look at in areas of like rare diseases and things like that, how those really affect minority populations. So that's really important too.
Thank you. Thank you so much for everyone's feedback. I really appreciate it. Give me a lot to work with.
Any other questions, comments, or concerns? All right, well, I want to thank everybody for coming. And we want to give just a quick introduction for anybody who wasn't aware of who MSHPG and who Howard Association Science Policy are. Also, just a quick reminder that on Friday, Dr. Bankston will be presenting about some opportunities at Journal of Science Policy and Governance, as well as giving a little bit of a introduction into, or more information into, the policy memos and what they are and how to write one. And we can all take what we've talked about here and move it into a beautiful policy memos. I can foresee a lot of people having awesome perspectives for people to see. So that's just a quick thing. So quickly, Morehouse School of Medicine Health and Science Policy Group. We are an interest group focused on Morehouse School of Medicine student awareness about local and federal science and health policy, and we're committed to community research or outreach. We have also affiliated with the National Science Policy Network, which is focused on helping to give training and opportunities to those in science policy. And so typically we plan events much like this. You're very much so welcome to reach out to me with an idea for an event, we can see how we can make that happen, much like this event. This was actually an event collaborating between Morehouse School of Medicine and Howard groups. We kind of just talked about it one day, and we were lucky enough to meet with Dr. Bankston as well and kind of make this into what it is right now. Also, we have done a voter registration event, and we've done some legislative process information sessions, and we're also planning a legislative advocacy day. So if you're wanting to jump in on any of these types of things, or if you're interested in developing something, contact me or follow us on Twitter. I think our Twitter is on the flyer if you're interested.
And we are the Howard University Science Policy Association. So our mission is to create scientific policy framework from the perspective of historically Black colleges and universities that balances and addresses topical science-related matters, impacting individuals, their families, their communities, and helping to preserve public trust in the scientific research and promote opportunities for scientific advancements. So we have some people here from our e-board team. If you're interested in joining or finding more of the things that we do, add us on Twitter or LinkedIn. I believe, well, it's supposed to be there. But feel free to send us an email, or I think it was at the beginning of his website, not website, I'm sorry, the presentation, our contact information. That would be great. Feel free to reach out to me. Yes.
We can say goodbye to Dr. Bankston. She has a meeting to go to. I don't want to make her late or
Yes.
anything.
But thank you so much for joining us, Dr. Bankston. It was so nice to have you here.
Thank you. I know you're almost done, so I'll just stay a few more minutes.
Okay. Well, if there are no other comments or concerns, thank you everybody for showing up to this information session / discussion. I hope to see all of you at Friday's session, where we'll hear a wonderful presentation by Dr. Bankston, and you can kind of pick her brain about publishing and opportunities within the Journal of Science Policy and Governance. Feel free to follow us all on Twitter. I'll put our Twitter in.
Yes, our Twitters are in the chat. Follow us.
Thank you for this. This was great.
Thank you.
Thanks, everyone. This was awesome. Hope to see you on Friday.
Yep, see you all on Friday.
Thanks. Bye-bye.
Thanks, Raechel and Jasmine.
Yeah, no worries.
Awesome.